surgical management of tubes, oblique, migs, erosions.
Okay, thank you, speaker. Thank you, panel. Thank you, the panelists, and thank you for the organizers for this opportunity to present in this meeting. I'll just start by presenting on some of my approaches to managing erosions in tube shunts and some of the bleb-forming mix devices. Here are some of my financial disclosures. Now, glaucoma drainage devices, GDDs, and bleb-forming subconjunctival MIGs are proven to be effective devices and treatments for refractive glaucoma. But erosion is one of the serious complications in these devices. You can see here the erosion in of a tube, and also it can sometimes erode in these bleb-forming MIGs, in this case a pressure flow. And management needs to be prompt, and diagnosis needs to be prompt. The incidence of these erosions for GDDs is not very high, but it is a definite complication that we see. In terms of mixed devices like Zen and pressure flow, it's rarer, but there has been some several case reports, including one from our institution in Melbourne, Australia, of Zen devices that has erosions. And the typical presentation, in fact, most of them are they can be asymptomatic, and that's why it's important to examine the filtration area every time you see a patient. But they can present with just conjunctival thinning over the area. They can be a visible plate or tube, and sometimes they can complain of pain and redness around the erosion. And of course, they have a risk of endophthalmitis. Some of the risk factors for the GDD exposure include diabetes, narrow palpable fissure, ocular inflammation, high number of preoperative drugs, previous surgery, combined surgery, inferior placement of the tube, and in pediatric patients. And the mechanism is thought to be relating to the mechanical pressure from the eyelids against the device, especially when there is a thin and scarred conjunctiva over the top. Diabetes also contribute to the ischemia of the conjunctiva that makes it easier to erode, and there's some thought of possible immune-mediated graft thinning. Ways of preventing the tube erosion include good tube tunneling, slightly longer tube tunneling. Avoid conjunctival tension when you suture the conjunctiva across the scleral patch. Avoid inferior sites. Sometimes you might need to double graft the high-risk cases, and manage ocular surface disease, and also regularly educate patients to look for symptoms. In terms of bleb-forming MIGs, some of the risk factors for developing erosion in, say, Zen and pressure flow, if there is a superficial placement of these devices, if there is insufficient coverage with tenons and conjunctiva, and if there is and you can prevent it by applying mitomycin C to a wider area rather than localized area around the device, and avoid excessive mitomycin application, and of course avoiding conjunctival buttonhole at the time of surgery. And all these devices need regular surveillance to look out for early erosion. The principles of management is Of course, that they should have urgent or semi-urgent surgical revision. Often they need some sort of patching over the device, and you need to ensure there's good conjunctival covering over the new patch. You have to think about whether you would want to leave the device in, or whether you might need to reposition the device or even remove the device. And if you remove the device, you have to think about how you're going to manage the pressure afterwards, whether you need to place a separate type of device elsewhere, do a trabeculectomy surgery elsewhere, or need to do a cyclodiode. So those are some of the things you have to think about. I'll just see if this plays. So how I approach erosion in a GDD is to really mobilize the conjunctiva around the device. Often the conjunctiva right near the device is very stuck down and a lot of scarring. So I usually inject some subconjunctival xylocaine to really billow up the conjunctiva, make sure I get a good mobile conjunctiva, and clear all the any epithelial ingrowth or epithelium around the device, make sure it's nice and clear, reapply graft material over the device, and resuture conjunctiva, and ensure the conjunctiva is not under tension and there is good coverage. Sometimes you don't get any good conjunctiva near the device. All the conjunctiva might be completely stuck down near the device, and you might be able to cover with sclera, but then you still need to cover with conjunctiva so that the surface heals. And one way to do that is that I've been using is a pedicle type graft, so you can mobilize a relatively mobile conjunctiva away from where the device is, and kind of rotate it to cover over the scleral patch graft. So and you need a very good assistant to make sure that the field is free of bleeding and so on. In terms of exposure of mixed devices, and so in this case, it's a case of exposed pressure flow. And this pressure flow, the exposure, I think it occurred because the pressure flow actually moved out of the wings of the pressure flow has actually moved out of the scleral tunnel. And so the wings actually have eroded. The way I approach it is that the conjunctiva around where the previous pressure flow is quite scarred. So I want to avoid placing the device in the same area. So I actually take out the pressure flow from the previous area, suture the tract that it once was, suture the conjunctiva, and the conjunctiva in the temporal area is actually quite mobile, and so I replace the pressure flow in the more temporal area. And in this case, I usually would put in a intraluminal suture inside the pressure flow to avoid excessive filtration early on, and that's a routine thing that I do. And then to avoid further possibility of erosion in the future, I place a scleral graft over the device. And then you can then resuture the conjunctiva and in an area with better conjunctiva. So in summary, GDD erosion and mixed erosion is a serious complication from these devices. There are some factors that can help prevent this from happening. You look out for diabetes and avoid, look out for eyes with very tight palpable fissures. And the surgical technique is also critical, and early prevention and intervention is important in preventing vision loss. Thank you.
Thank you, Joe. That was really wonderful. And all of us over here have faced that so many times. One trick, because what actually happens is that these patients go to ophthalmologists who have no idea what water tube is. So, and they will just look at the tube in the cornea. They are seeing there's no tube corneal touch, and they're just looking at the pressure and they say, oh, everything is fine. So I tell these patients to tell them that, okay, there's some itching here, please look like this. And they just pull up their lid and show them, because sometimes it is there and the doctors will miss it.
Yeah.
So I teach each of my patient to actually show that other part of the tube, which is where the erosion occurs.
Yeah, very good comment. Yeah, absolutely. I have to always examine that area every time when examining the patient who had a tube.
Yeah, we would, but most of the other ophthalmologists don't have an idea.
Do you always cover your tubes with a graft?
Yes, I do quite often. In our institution, we have ease of access to graft material, both sclera and cornea. There are, of course, a lot of centers that don't have ease of access. I've been to operate in areas where there isn't, and in those situations, I do a scleral flap.
So George, do you find like erosions are more if you don't use graft or something? Because we have been covering them with a graft, for many years, and for the last couple of years, I'm not using, putting graft. I'm just tunneling them into a long tunnel, and that is like 2-3 years only. It might happen later, but so far I haven't seen any additional or more exposures after that. So I was just wondering whether, if you're tunneling the tube through a long tunnel, maybe you don't need a graft.
Yeah, absolutely. I think that one of the reasons why tube erode is where the kink is, where the knuckle is of the tube. So if you make a tunnel, then you don't get that knuckle effect, and so it's less likely to actually erode. In centers where there is grafting material, then some of my fellows, they actually try to place the tube closer to the limbus, so it's easier to go in, but then it creates a really big knuckle, and then you put a scleral graft over, and it still erodes over the scleral graft, like you said. That's great. Oh, hello.
I was actually going to say about the bending, because the dolphining's a classic thing. The other thing is, I'm sure that tube movement has something to do with it, because when they're knuckled like that, they're kind of doing this all the time.
Yeah.
We actually published a retrospective of 74 tube erosions repairs. This is not looking at the risk factors for erosion. This is looking at the risk factors for re-erosion if you've repaired one. And the two things that came out as being risk factors for re-erosion were, firstly, not repositioning the tube at the same time. So we pretty much always reposition. Obviously, if the tube's in an ideal position already, then you think, well, what can you do? But usually, if you put it further back and shorten the external course, I think it's shortening the external course is probably why repositioning seemed to be beneficial. The other risk factor for re-erosion was using pericardium, because it just disappears. So we tend to do, we use sclera or cornea or fascia lata, but pericardium seemed to, we can't comment on tunnels because we never do them, but people do report good results with tunnels. But I would caution against the use of Tutoplast pericardium, because it does vanish. The other one point, sorry to go on a bit, is we used to always use proline at the limbus, and the proline sutures sticking up seem to be a big cause of erosion. So we switched to nylon, which is a little bit less pokey. And I found the trouble with proline is it's still around 10, 12, 13 years later. And I had an erosion recently on a guy that eroded after 13 years, and it was the proline knot. So that was just one other thing that we noticed.
Oh, okay, yeah. Thank you.
A group
Keith,
just published from Indonesia on 238 tubes, and they've got about 5 years follow-up from a local design. They didn't use any sclera or anything else, they just tunneled them. Now, I'm not sure the follow-up is perfect because they came from large areas, but they said they had no erosions. So they said it didn't have a high rate.
yeah, yeah, and yeah. So having less of a curve and actually longer tunnel actually it's a real good technique to avoid erosions.
Sclera just erode and disappear after many years. If you follow them long enough, even that sclera is never ever seen. So we
Yeah.
we really realize, where is the sclera gone? It's not.
Yeah, but it's the odds. Scleras do disappear, but a lot of them don't. Whereas with pericardium, 100% of them disappear almost. Whereas in sclera, there are patients that got that sclera 20 years ago and it's still there. So some of them disappear, but a lot fewer of them do.
But it can create a pseudo-tunnel, so it can erode right underneath it, and then you have essentially built up in sun, so it's much less.
And I think you did mention that ocular health, the ocular surface is important too, because if there is a stagnation of secretions or the bacterial buildup in that area, and if you have a thick like a graft there which is causing that step kind of a thing, there is creating a dead space around the tube. I think that might be a factor sometime that could lead to.
Whether they